Ski. I am co-founder and CEO of Go To Pills, an information bureau for off-label medications that is currently being integrated into Walgreens and will be available hopefully by next month. I have the pleasure of introducing Dr. Patrick McGinnis, who will be our moderator for the Grand View from Clinicians. And Dr. McGinnis is the Director of Medical Informatics at Memorial Hermann Hospital, where he and his team are focused on driving the adoption of and enhancing the clinical utility of EMRs. And Dr. McGinnis is adjunct professor at the UT Health School of Biomedical Informatics. And before coming to Memorial Hermann, he was with Cerner and served as a flight surgeon with the NASA astronauts at Johnson City Space Center, providing primary medical support for several space missions. Dr. McGinnis has broad medical experience in the private, public, and academic sectors, and he is board certified in aerospace medicine and was one of the first recipients last year of being board certified in the specialty of clinical informatics. He has served as a congressional fellow in the U.S. Senate, and he serves as an elected city council member for the city of Friendswood. Welcome, Dr. McGinnis.
Well, thank you. Well, I've got an all-star cast here this morning, and Clark, Dr. West, is the only one who had the fortitude enough to put some slides together. So we're going to let him go first so he can present his slides. I think we'll see some themes. And what I've asked my panelists to do is to approach it first with our pain points, because pain points, you know, the corollary of that is opportunities for improvement, opportunities for new businesses and investors. And then we'll go from there. And this can be interactive as we like. But before we start with Clark, I would like my panelists to introduce themselves so you know the variety of clinical training that we have.
I'm Matthew Arbison. I'm board certified in internal medicine and pediatrics. I run the hospitalist group at Memorial Hermann in the Med Center, so there's about 25 of us.
Clark?
I'm Clark West. I'm a radiologist with the University of Texas. So I can see our logo, the dean likes it if I put that up. I'm mostly do clinical practice, but on the side I'm vice chairman for both clinical operations and imaging informatics. I have no formal informatics training. I've just picked it up off the street over the course of my career.
I'm Nicole Pardo. I am co-founder and CEO of a health IT company here in town called Online Technologies. I'm a general physician, but I went to the dark side so many years ago, first in biotech, then in medical devices, and most recently in health IT. That's it.
I'm Monica Verduzco Gutierrez. I'm a physician board certified in physical medicine and rehabilitation and brain injury medicine. And I'm one of the staff physicians at TIER Memorial Hermann, as well as at Memorial Hermann in the Medical Center. And I was also the co-director of the outpatient clinic at TIER, and so worked very closely when we developed the clinic care for the outpatient clinic.
Okay, Clark, take it away with your slides, and then we'll start the general discussion.
I've been practicing for 21 years. Most of the time I've been somehow involved in the developing electronic health records. So one thing that's changed over just the 21 years of my career is we've gone from a mostly film and paper world to an all-digital world. And diagnostic imaging became all digital about 10 years ago. Everything we do now is a computer transaction. I spend my day sitting in front of very large, very expensive, high-resolution monitors. So every step involves computers. Each step is on a separate system, usually from a different vendor, or from the same vendor but in a different module. That's a big problem. Lots of different vendors. How did we do that? My slides went off the mug. Oh, it's because it's using a Macintosh instead of a real computer. Okay, anyway. So, I'm trying to remember what my point was. Oh, they don't integrate necessarily. We have standards, and they kind of talk to each other, but usually poorly. And my final point was, often in those system-to-system transactions, we leave off stuff. We truncate a field at 256 characters, even though the other system allows you unlimited text. And so we get part of history. That doesn't happen at Herman. It's actually an accounting system where that happens. So these are problems. Let me give you an example. We're going to order a chest x-ray on an inpatient, and it's after 5 p.m. In our hospital, that makes a difference as to where the thing goes. So the physician orders the x-ray on a clinical workstation. The ability for physicians to order things directly is fairly new, last 2 or 3 years. Probably a good thing overall. There's background transactions going on. The hospital information system sends the order into the radiology information system, which is a separate module within the electronic medical record. And then that goes on to a printer where we make a piece of paper that we use. The piece of paper is our interface. The lead tech in our place then will receive the order on a separate and completely independent system. We'll put an order in to have the patient come to the radiology department. No integration. It may have the patient name as sort of a shared information. Magic occurs. I have no idea how that process works, but the patient does appear eventually. And the patient arrives in the emergency radiology. That's my area, and that's where things are done after hours in our hospital. And the patient's taken to the x-ray room, which has all digital equipment. So those are separate computers that do imaging and are partially integrated. So the technologist chooses the correct exam from a work list, and that is an effective integration these days, is sharing the work list with the x-ray modality. Fairly new, last 7, 8 years, but that helps, and so there's a radiology information system to a modality interface that allows that to occur. The technologist will typically only do 2 views because the computers behind the new digital x-ray equipment are setting the techniques and adjusting for patient size and doing a lot of things that required artistry before. So it's much less likely we're going to repeat something or do it wrong, and that's good. The technologist looks at the images on the x-ray modality and manually triggers a send to our picture archiving and storage PACS system. That manual command is appropriate because they need to make sure they did it right, make sure the images are decent quality before that manual operation occurs. We have all sorts of interfaces in there. Modality to PACS. Fortunately, we have a standard for that that's widely adopted. It's getting a little long in the tooth, but it still works. There's another one where the technologist can signify to the computer world that I have completed this exam. That's not implemented. The standard's been around for a long time. Most of, I think 1 or 2 of our portable x-ray machines now has it, but it's mostly not implemented, even though it's been around a long time. So the technologist then has to do electronic paperwork on 2 separate systems to say, I have finished this exam. That takes time. That's a real waste. And so that's both radiology information system and PACS data entry. Okay, after all of that occurs, finally, the x-ray appears on my PACS work list. That's pretty well designed, and it involves a whole bunch of transactions, most of the radiology information system PACS. I open the exam, I interpret it. That's the shortest part of the whole thing. It takes me about 35 seconds to do that. Then I have to create a report, which is actually going to take quite a bit more time. And I have a voice dictation system, and there are all sorts of interfaces. One of them is actually bidirectional, where they share information in both directions to the radiology information system. The report goes from the voice system to the information system, to both the PACS and the hospital information system, and finally the images and the reports are available. So, what do I wish? This really is a rotten system. It's very hard to use. All of the interfaces are old. The concepts are old. What I really want is a well-designed, fully integrated system where all of these steps are so inherent that I don't have to deal with it. My voice system should be integrated into my PACS system, not sitting on a window on top of it, for example. And so it's really the integration and the making it easier to use that I need in the future. That's my pain there. Let me tell you two other areas where we really need help. One is real-time provider communication directory for each patient. For any given patient in the hospital, there's no good way to know who's caring for them. Nurses, which teams of consultants, who's even the primary doctor. Hit or miss. And the bigger the hospital, the more difficult it becomes. So the big university hospitals are where it's a problem. Further in the future, I would really like to see FedEx and UPS technology. If we know patients are going to have these tests done, and I know the resources available, an intelligent system should be picking the optimum schedule and getting all of that done, not a series of phone calls and separate scheduling steps. That's a ways off. That's a complex task, but it's done in other industries. We should be able to do it in healthcare. And that's all I have.
Thank you, Clark. Continuing on. With that theme, I'd ask my panelists to tell us your pain points of, all this technology is great, but where are you hitting a brick wall? Matthew, I know I hear from you weekly about these things.
I think it ties nicely into the last discussion a little bit, the conversation between data and information. The electronic health medical record, right, EMR currently is all about data. And what you've seen since we've really implemented electronic progress notes is the narrative is gone. So the current generation of trainees have not learned how to put that story in a usable fashion into the medical record so that I can pick up that patient's chart in 6 months from now and recognize that when they were on that person's service, this was actually what happened. Right now it's a bunch of data points, very fragmented language, and most of the time it's really hieroglyphics, and you're just trying to figure out from one day to the next what happened. And then that's further complicated by each specialty has their own kind of standard of documentation and language. So that's one piece for me, is reinstituting the narrative in the written note. One of my mentors, he used a blue fountain pen, and I still have his. He wrote beautiful, poetic notes, and you knew what he thought and where that patient was going to go. And most of the time, he predicted their mortality and things like that. It was very entertaining. The second one for me is the regulatory environment in the requirements in which I work is so vast that it's very challenging for us to keep up. And then on top of the regulations, other people are interpreting the regulations. So there are lots of people who are 200% compliant, which makes my word choice so challenging that we get what they call poor measure fallouts for word choice. And we have to move past that somehow. And if it's building smart discharge summaries, which is what we've talked about, or things where the regulatory requirements are easy for me to meet in my normal workflow. Some of the EMRs, a great example for me, for a long time I did discharge summaries in a particular way. I put a lot of information that I thought was going to the patient for about 3 years in a particular box, only to find out that that box actually doesn't populate anything in the discharge summary. It was a big revelation to me. So those are some of the challenges I think for us in the regulatory environment is really running a large group practice with all of your quality data published online for a technical error, putting the right words in the wrong box to affect your quality. That's a relatively simple solution. It's not a simple solution, but it seems like a relatively simple solution to build smart templates or smart documentation or things like that. So those are the two things for me personally.
And Nicole, as a physician and entrepreneur, you're probably trying to solve some of these.
Well, we are, but I want to touch upon some of the same points that Clark and Matthew have talked about, and it's the fact that putting the data into the system is so time-consuming, and we're taking time away from the interaction that we have with our patients. So it just recently happened to me. I went to my own physician, and the guy didn't even look at my face. He was typing in front of the computer. So it's like they're taking away that specific thing that when I went to med school was very much, taught by my professor saying, you have to look at your patient, you have to see what's outside, what they are telling you without words. And that's not happening anymore because we're so focused on putting the data into the computer. So that's one of the things that is very important. And then you just mentioned it too, the degradation of the clinical documentation, because I'm putting data into a box thinking that it's going to go into my patient or for the discharge, and soon I realize it doesn't happen. So and it's not just the information that goes into the patient, it's the information that I'm passing to my colleagues to make sure that the next time this patient is being seen by somebody else, they understand what was my thought process there to treat this patient. That's not happening anymore. I'm looking at data points, and I don't even know what those points are anymore. So I think it's very important the simplification. Technology wants to simplify things, but we're solving problems, creating sometimes larger problems for our practitioners. So that's what I have there.
Monica, tell us how it is at TIER, or adopting rehabilitation medicine with these tools.
So the positive is, since Memorial Hermann is connected in the EMR, it's nice if patients come from there to our rehabilitation hospital, that we can kind of see what's been going on, see who is following them, be able to contact those physicians if need be, have the discharge summary right there and not wait on, will they fax me 1, 2 days later where the patient's maybe on completely the wrong thing that they're supposed to be on. And so that's nice. And then we implemented the clinic care for, so that's the outpatient module with all the meaningful use criteria that we're supposed to meet. And I think that's really good as well. So part of the negatives, like you're saying, you're facing the computers now more than you're facing the patients. Everything's like we have to put in, we have to do our notes. You lose time, the number of patients you have to see. If you're just waiting to dictate it all at the end or do it later, then you're then stuck in the clinic for a really long time afterwards. And then you may miss some of the subtle things. Some of the older physicians can't quite grasp it yet, too. They're having a lot of trouble with, you click these, you put a click here, and then you press OK, and then you print it, and then the patient gets their discharge papers. And those two, clicks are too difficult. And then they can't meet their meaningful use criteria, and then we get a big ding and we lose, our 1% for Medicare or whatever it might be, just for those things. And also the nurses are able to do it, but somehow they're not meeting the percentage they're supposed to meet. So that's a pain. I don't know how to make that easier or just more training for them. Maybe it's a training thing. I guess with EMRs in general, all of the information that we get, and a lot of it's just copied forward. The same idea that's there is copied forward. So, I was saying, I do brain injury medicine. There's a patient that I'd seen, he was maybe YouTube. It said he was in an MMA fight, that's at mixed martial arts, and he got a brain injury. And it just, every note was he had this brain injury from this and this. When I talked to the parents, when you finally talk to them and ask what happened, he's a boxer. He's not an MMA. That's different. They were really offended that it wasn't, that they weren't saying he was a boxer. And so it was 50 notes, and sometimes other little things can be, from a medical legal perspective, you're saying this patient has a husband. Well, maybe they're not married, or maybe they're not claiming that they're man and wife. So that makes a difference also legally as far as who's the medical decision maker in that case. And that's something that you've just been saying in the chart that's just passed on forward, forwarded on and on. So I think that's another problem with EMRs.
Yeah. So I'm not practicing anymore. I'm probably one of those older doctors that Monica mentions, because I grew up writing everything, but luckily got into healthcare IT. For me, as someone who is trying to oversee a lot of our IT projects within Memorial Hermann, I'm very skeptical on the regulations that are coming from the federal government that we have to deal with. I often say it's the tail wagging the dog. For the losing the patient story, as Matthew mentioned, a lot of that is because doctors think, well, if I don't document, then I'm not going to be able to bill correctly, and my office is going to lose money, etc. So the electronic tools just give you an easy way to dump everything into the note, but then the next time you go back or when your colleagues read that note, it's, they have a tough time finding the nugget of what's important to that patient care. Meaningful use, which I'm sure you've all heard about, I can't tell you how many doctors have said, well, we're doing all this stuff, but it's not really meaningful at all. It's just, we're jumping through hoops to do this, that, and the other thing. So I think as many have said today, and all of the technology and the rules that come along with it are detracting a bit from the physician-patient relationship, and you can't tell that patient's story. So these are still challenges to overcome. I guess one of the things I asked my panelists to do, if you were king for the day or if you were a venture capitalist and you could direct where things would be changed, where would you do that? So for me, it would probably be in the standards area. So we wouldn't have such disparities between the various EMRs or other sources of information. What about you, Matthew? If you were in charge and you could make these things work better, what would be the good thing?
I'm a firm believer in universal EMR. I don't know how you get the data in there, but I did in residency work in the VA system, and I could see your clinic visits in California, Connecticut, and when I saw you in North Carolina, which is a big positive. Now, very large, very clunky system, but it definitely had its advantages. And then just, they're talking about, my wife runs a clinic, and the only way for her to be more successful is to see more people. And that is all about workflow. And workflow is getting more bogged down. So it's really, it's more ergonomics for physician workflow. And a lot of people who are designing these systems aren't at the bedside and trying to get that done. There's things that seem intuitive, and so I think it would really be to do that, to develop it ergonomically around the workflow, which is different for myself and all of the different panelists and all the different medicines that we practice, and I think that's the big challenge.
What do you think, Clark? You talked a lot about interfaces.
Yeah. So I think we're seeing the same thing here, is the more we become fully digital, the less efficient we've become in many respects. Some things work well, but my daily workflow, I spend much more time fiddling with the computer than I do interpreting the images, which is my main mission. And that's a problem. I have a question for the audience, since I'm not getting remunerated in any other way, which is, how long should we keep your images? Here are the choices. 5 years, 10 years, 30 years, or for your whole life. So,
Who says 5 years?
So why are these choices even there in the first place, given this day and age of almost limitless storage?
Let's play this game.
Why are we even asking this question?
I'll answer that.
Speed.
Let's go for 10 years. 30 years. Whole life.
Why are you keeping them? Why aren't we keeping them?
Okay, my bias. I think we should keep images for your whole life. I think we should have a centralized data warehouse for everybody's images, so that they are available universally, and I think patients should control who gets to look at their images. That's my bias. Other people in our organization say 5 years. That's the regulatory requirement. We should remove them.
That you open up. So if you extend that and it takes me to access today's image because everything's behind it, 5 seconds to get that image up, multiply that over the course of my career, and I have lost 3 or 4 years of patient care. And it's that speed and accessibility. That's my big word.
One reason why this is coming up, it's a policy issue. So he mentioned, yeah, that's the law. And previously, images did deteriorate. Films took physical space to store somewhere, so you had these policies about putting it into archive or the long-term archive, and then you could get rid of it because it was deteriorating anyway. But now, do digital images deteriorate? No. So it's maybe a new paradigm that policymakers need to think about, that images really could stay with a patient for a lifetime.
So I don't buy into the argument that, it takes 5 seconds or 10 seconds. Yes, if it takes, then it is flawed.
Yeah.
When Google can serve up search results, no matter where you are in the world, in a sub-millisecond, then there's no reason why, IT systems in healthcare cannot be fashioned.
But they don't right now.
But they don't.
That's why we're coming from a very skeptical place, because most of the things that promise big leaps forward in our ability to get stuff done or get stuff done efficiently or more effectively or keep that narrative, when delivered, come with a cost. The vast majority of that recently has been, and I think some of it's because of the secure connections and things like that, comes at the cost of speed. And
So you're absolutely right in saying that we need to, these need to perform, but let's not throw the good things away. Let's not destroy the data so that we can buy some performance. Challenge, push back at the right places.
These are the guys that do a lot of pushback.
we need to push back a lot.
Nicole, what do you think? If you were queen for a day and could magically change the healthcare IT landscape or what you use?
Well, definitely one of the things that even though VCs are not invested in electronic medical records anymore, they should definitely keep investing in building those pipelines to make all these places communicate with each other, because it's not about having the data, it's about getting the data across the bridge. Because right now, even if I use Epic in this institution and in the next one, those two Epics are not really telling me anything in between, right? So it's getting the data across, and I know Phil Decatur is one of the pioneers doing this in town, and it's a matter of eliminating repetition. Yes, I don't want to know everything, every single visit that you had with your other doctor in the other clinics, but if I'm looking for something in particular, simple medication reconciliation is so difficult to do these days, and it's something so simple that we can solve. So yeah, let me talk to your Epic in whatever institution you are. I just want to know what medication they're taking. By the way, that's what Remind Technologies is intending to do as well, which is very complicated. So I think it's a biased answer there, but pipelines to communicate everything. Yeah.
I belong the same with universal EMR. I wish our EMR, in the Memorial Hermann system, our EMRs talk to each other. I can read what happens at other hospitals, see the radiology, whatever other reports. So that is wonderful. But if someone's a VA patient, I don't know what happens at the VA. And so it would be great if those somehow could talk. The med reconciliation is a big thing. That's big. It's really hard to do for inpatients and when people are discharging it. That could be done, and then I could e-prescribe from inpatient. That would be great. And then faster. By the way, it's very slow. Yesterday and today.
Yeah, yesterday was terrible.
Yesterday was terrible. And killed me in the
Sorry.
clinic, by the way.
Yes, sir.
So I know one of the major challenges would be having this be cloud accessible, because I know a lot of the times, one of the hurdles we have, every other CIO seems to be on board for the cloud or saying absolutely no way. How can it be patient-centered and travel with the patient if it's not allowed to leave the four walls? So I'm curious what you guys see the trend being, and if there are ways that we can get healthcare on board with maybe cloud technology.
Well, for the Memorial Hermann system, which is all I can speak to, our privacy officer and our privacy policies are really strict and controlling, because no institution in the medical center wants the ding that, your patient's data got out or you were hacked, etc. I think what we're doing and other places are doing is the patient portal, where we're adding more and more capability to that, which, by the way, generates its own new kinds of problems, but that's our way to have things at least accessible to the patient. We're also embarking with Cerner's, our vendor partner, on population health, such that within our EMR we can gather data and present it in an informative way, and not just pages and pages and screenshots of things from another vendor. But it's vetted through various algorithms, so it presents useful information to the providers.
And I think the regulatory environment and the punitive nature of information leak makes everyone so absolutely fearful, because if you are that first one, you're done. I mean, you could take down a major healthcare system in the United States with one big bad leak, and that's what people are so afraid. And then you see, all you have to do is watch the news. You don't even want to carry yourself.
The security precautions really are getting in the way of research. It's hard to do research. Very strict interpretations of the privacy rules really stop the free exchange of information, even from sending a patient from a community hospital trauma center to our trauma center. We've got people who won't release information even though that's clearly covered. They want a form from a patient who's comatose and has no family.
What do you guys think about patients like me and things like that are, patients able to share their own information and, do you think that can help combat some of that?
Yeah, I think that's one of the solutions.
And I think the city of Houston presents a unique challenge to practitioners, particularly in the acute care environment, because there is a rotation. They will come to a permanent hospital, I will discharge, they'll potentially go across the street to Ben Taub or come down the street to Lutheran or Methodist, spend some period of time in those healthcare systems and then rotate back. Tremendous duplication of effort, and oftentimes it creates a lot of other issues. In a monolithic city with a single healthcare system, I don't think they see some of the issues that we have here in a robust, competitive market. So if you came with your microchip, it would be great. But we had one patient that we found, one of a very diligent case manager, social worker who had contacts, found out that that patient had spent 325 out of the last 365 days in a hospital bed in the city of Houston with relatively no medical issues. 325 out of 365. It is, and that's, part of the reason healthcare is so expensive is because we don't have the capability of recognizing that as an issue and making an intervention to what that issue is, potentially. And I think to Dr. McGinnis's point too, population health is such an opportunity for us, but without that free flow of nature and looking at metadata, it is challenging to come up with clear-cut plans to move that forward.
Isn't that what your HIE is for?
Yeah, that's related to the HIE as well. They're parallel efforts, let's just say. The HIE would strictly be bringing information in, but the population health is also to add some intelligence to vet that information. Well, I got the sign that we have 1 minute left. I would be glad to take another question from our audience. And
Right up here.
I was wondering, as physicians, what are some critical information pieces that patients should have with them? Like that, if they had an app that just had that record, but not necessarily integrated into an EMR or anything, but what would be ideal to have on that app? Like, in addition to medication.
They have their meds.
Yeah, meds is probably the key. In the previous panel, they were talking about that, and the patient portal is a whole nother piece. Doctors don't want all that data. Patients don't know how to interpret a vast majority of the data. So if Dr. West does a very thorough read on a radiographic study, there might be 27 findings, which are all fine. But I will spend an hour with someone going through all 27 of those findings and go, that's actually a normal finding, that's actually good for you, and so that patient portal is a whole nother challenge for us in a fast-paced world. But meds, if you know what you're on, I can read and figure out what you got.
And who your doctors are.
So
Yeah.
doctors, allergies, meds.
Problems, problem list, that's the key, and past surgical history.
We'll disagree on the problem
I
list.
think problem lists are really valuable.
So problem lists it's all about data in, data out. So the only valid or important problem list to me is one that has good data in there. People think all kinds of things are problems. Stub your toe. They showed last night one in our combined IT meeting where someone listed as a problem wants someone to brush their teeth every day was a problem. And so stuff like that is just more data for me.
And your insurance. Similar.
Yeah, but just to give a number on that, 86% of the patients go to Google before they go to the doctor. So they come prepared with a whole bunch of things that you have no idea how to answer, right? So health IT is here to stay, not just for the physicians in the electronic medical records, but for the patients to, gather all the data they can from the outside using Dr. Google and come back to your provider and try to solve those issues. So.
I think there are two solutions. One is a monolithic government health system, which seems not very acceptable to the American populace as a whole. The other is patients taking charge and putting their information in a system like Google.
I'll disagree with Clark on his first point, but that would be the subject of a whole nother panel. I
Yeah,
think we have one more question.
One more
on this.
question.
I have a real quick question, because with Memorial Hermann being an ACO agenda talks among its system, is the government looking to you all for the learning organization conversation for them to continue? Is the government approaching you all for your input to make what they're trying to make us all do better?
Yeah, well, I believe they are, but I don't think any of us are at those executive levels having those
That
kind
was
of
a yes or no.
conversations.
That's all I.
All right, thank
I hope
you.
the conversation happens.
All right, great panel. Thank you, everyone.